A common theme of today was the importance of relationships and partnerships, and I suspect that that's going to be a common theme through each of these presentations today. My name is Hope Smiley, and I am the Program Director for the Investigative Sciences program here at RTI. Today, we're going to talk about addressing drug use through innovative approaches, including harm reduction and intelligence. And I'm proud to announce introduce the following presenters. Melissa Larson is the Law Enforcement Program Manager from the North Carolina Harm Reduction Coalition. In this role, she helps law enforcement agencies implement harm reduction approaches and services, as well as the law enforcement assisted diversion programs across North Carolina. Prior to this, she worked for over 19 years in the criminal legal system as a project director, including law enforcement agencies in the East. Next, we're going to hear from Bill Hollingshead, who retired in 2019 as the Waynesville Police Chief after 36 years in law enforcement. He is the current Executive Director of the North Carolina Association of Chiefs of Police. He has served North Carolina across several commissions and task forces, including chairing the North Carolina Criminal Justice Standards Commission. He served on the Attorney General's Task Force on Opioid Abuse and the Governor's Task Force on Alcohol and Impaired Driving. He is a graduate of the FBI Academy Command College and the Southern Police Institute. And finally, Bill Lux is an instructor and a developer at the North Carolina Justice Academy. He retired after 16 years in law enforcement and from the Nashville Police Department in Tennessee, not North Carolina. In his career, he worked for 12 years in narcotics and gangs, and he now serves as a reserve deputy with the Henderson County Sheriff's Office. I'm excited to pass the baton over to Melissa Larson, who will lead us off.
Thank you. How's everyone doing? I really appreciate you guys still being here, the Lone Rangers at the end of the day, right? So we're going to talk about harm reduction a little bit and some law enforcement initiatives that maybe would be of interest for you to take back to your communities. If you're not familiar with North Carolina Harm Reduction, we are a statewide grassroots agency, a nonprofit agency. We work with individuals who are directly impacted by sex work, by drug use, by incarceration, by poverty, by health-related outcomes such as HIV and Hep C. I've got a bunch of stuff that I want to talk to you about, but I've only got about 15, 20 minutes. So I'm going to try not to talk too fast, but I am certainly available for any questions that you may have. What I'm hoping that you take from this is opportunities to take it back to your community, tips and training ideas for your officers, also data that you can use to develop responses for your community and for your agency, and then just program ideas in general. And so my approach is education-based. I understand that, you know, there's a lot of law enforcement in the room, but there's always room when we develop our programs to have both education and enforcement deliverables or outcomes when we're developing programs. So is anyone familiar with the concept of harm reduction? Yes, for the most part, couple a little bit. Okay. It's a range of public health strategies that are designed to reduce the harmful consequences associated with drug use, with sex work, and other high-risk activities. I also like to think of it as a philosophy as preventing disease for individuals and really meeting people where they are, not being judgmental when we try to assist them. So harm reduction can go into very different venues. For example, did everybody drive here today in a car? Yes, I assume so. And you wore your seatbelt, right? That's harm reduction. And when you maybe went and bought your car, you made sure that it had seat belts and it was a safe vehicle. That's harm reduction, because what you understand is what you're doing is very risky, right? Driving is one of the riskiest things that we do all day. And if you're in the profession of law enforcement, you're practicing harm reduction every day there too. You wear a firearm, you wear a vest, you go to training. What are the two most dangerous activities that you do all day? Most officers will tell me driving and going to domestics, right? And so we go to training for that, so that maybe we're separating people, we're going to DV calls, we're approaching vehicles in a certain way, because we understand that what we're doing is risky. So you guys are practicing harm reduction too. The context in which I'm going to talk about harm reduction is for people who are actively using substances. So a couple charts here, not to dazzle you too much, but these are state charts of the naloxone distribution that's going on in North Carolina, to include some of the overdose data. This is available on the state website. I put the website address on there. It's Injury Free NC, and it's through the Department of Health and Human Services. They've got phenomenal information they put up every month and every quarter and every year too. So this first one, I think that every community should be looking at it on a monthly basis. This is your opioid overdoses that are coming into your emergency department. And so it's really interesting and good to know where your community stands when you're developing programs and you're partnering with your communities. This first one, for example, comes out of Lee County. I'm not sure how much detail you can see on it, but what you want to look at is where it says 60 and where it says 80. So what we're looking at is from January to December, they had 80 visits to the ED for an opioid overdose. The next time frame, 2019, January to December, the number had gone down to 60. So we can attribute that to more naloxone in the community. We can attribute it to any kind of response that public safety and public health have. So there's a lot of reasons, but you want to keep looking at this on a monthly basis because it will ebb and flow. The next two are hotspot maps. And so these heat maps are always really good to look at. The first one is for opioids and the second one is for heroin and synthetics. Now what you can see at the bottom of the chart on the bottom left is some of the top communities. So for example, that second one, your highest rates of overdoses, I can't see it, but I'm kind of visually impaired at this point at my age, but if you go in and you check this out on the website, you'll see they've got like Stanley County, Carteret, Craven, Burke, and then it looks like Robeson County. Nobody ever wants to be on this list, but sometimes when we find ourselves on this list, it just means we need to work harder to develop some of our programs. The bottom one, speaking about naloxone programs for law enforcement specifically, that is our map of all the agencies that are carrying it. And since the law passed in 2013, there's been a lot more law enforcement agencies jumping on board because you recognize that this is a good strategy. We all get into the profession to reduce injury and death, right? And to help people and to save their lives. Naloxone has been a great program for law enforcement. So we've got 259 law enforcement agencies carrying naloxone, covering 90 counties. Anybody in the room in white, I would love to talk to you. Maybe you are carrying naloxone, I just don't know it, or the state doesn't know it, or maybe you've got some questions about it and we can talk about that. The final map on there is the overdoses that are reported to our agency, NCHRC. We've been tracking this information for a couple years. The reason that we want it is because this is how we justify getting more naloxone for law enforcement agencies. So when the state, or maybe we're writing a grant, they say, well, how many agencies carry naloxone, and then how many reported overdoses and administrations do you have? If you don't share it with us, we don't know. And so this is not completely accurate data, but it does give you a good depiction of the partnership that we have across the state with law enforcement agencies. A couple slides I wanted to share with you. Again, these come from the state website too. I know that with law enforcement over the past couple years, as fentanyl has been on the rise, there's been a lot of conversation about, okay, now instead of one dose, we need multiple doses. And there comes a cost with that, right? This stuff is not inexpensive, naloxone in itself. So I wanted to share this chart with you. This is 2016, 17, 18, and 19. So if you look at the green, that is one dose. So you can see it's significantly decreasing as these years go. And then 2 and 3 doses, opposite effect, they're increasing. So as we talk about fentanyl, we can move to the next slide where NCHRC, we have fentanyl test strips, and we pass those out to our participants that we work with because we want to make sure that they have an ability to test what they're using. Everyone in this room can go to Walgreens, CVS, Walmart. We can all get our prescriptions. They're all FDA approved. We don't have to worry about if it's tainted with anything. People who are buying drugs out on the street, they don't have that ability. And so if we can give them this little package, you see this picture here, it's a $1 strip, and it kind of acts like a pregnancy test. They just dump it, or they just dip it into their substance, and then they can find out whether or not there's presence of fentanyl in it. And so if they report back to us that there was, then it helps us track what's going on in those communities and where we need to increase services. So you can see a significant increase of fentanyl in drugs in that second slide there. I put this last graphic on here. This is a great recommendations that came from the DEA and other federal agencies. I always encourage agencies to share this with your officers. There's a lot of misconceptions out there about the risk of fentanyl for officer exposure. And so this is a PDF file. There's also a training roll call video that's on the DEA website. You can simply just Google safety recommendations for law enforcement for fentanyl. Make sure that you're using the one that came out in 2017 because it really clarifies some information that was previously reported about the inhalation of fentanyl and the risk of that. And so 2017, the feds, they cleared that up to say simply touching fentanyl, for example, did not have that high level of risk that inhalation does. And so one of the things that we always talk about in harm reduction is that if it was the case in which individuals could simply touch fentanyl and they could die, then we wouldn't have people in healthcare, we wouldn't have people in law enforcement, we wouldn't have people using IV drugs because they would just put it on their skin and then the effect would happen there. So we have to be really realistic about what this risk is. And when we have officers who are out in the field and they have some concerns about whether or not they've been exposed to fentanyl, the other recommendations are really understanding the effects of an overdose versus something else that's going on. So an overdose, sluggish breathing, maybe not breathing at all, they're not communicating. It's the exact opposite of what may happen in an anxiety or a panic attack in which we have a heightened sensitivity. We're communicating with people, we're breathing, our heart is racing. And so it's really important that we understand the differences between those two so that we can help our officers when they need it. So sustaining your naloxone program, that's been a really big issue over the past couple years. You know, you can get a 2-dose kit for about $75. That's a lot of money for law enforcement, and it's a lot of money for EMS too. And so I've got some recommendations for you as far as sustaining your program. So if you don't have a relationship with your MCO, your managed care organization, I suggest that you find out who they are in your community. Just Google North Carolina MCO. Could be VIA, could be Alliance. Just check them out, find out who in that organization is invested in community distribution of naloxone, because chances are they may have some funds for first responder naloxone too. Also, your public health department, they have access to different types of funding streams, could be grants. If you have a partnership with them, you can say, hey, next time you have an opportunity to get some funding for first responder naloxone, don't forget about us. As a law enforcement agency, if you have a good relationship with EMS, there's always an opportunity to swap the medication there. I've seen examples where they are using the same device. And so if law enforcement is getting ready to have theirs expire, they'll work with EMS and say, hey, this one's only got 2-3 months left. You're more apt to use it than I am. Let's do a switch. So there's lots of opportunities there. If you are a part of a school or an organization or a library or a YMCA, ADAP Pharma, which is now called Emergent, they have a couple programs to get free naloxone kits. And so if you go to Narcan.com and then click on community programs, there's a quick little application they have that you can get a couple free doses for your smaller organizations. Look at that. Oh, and standing orders. I don't know who in this room has had a problem with standing orders. If you're a law enforcement agency and you're looking to purchase your own naloxone, what I've been told by many agencies is that the challenge is the standing order. So North Carolina has a state standing order, but law enforcement's going to need their own local standing order that's signed by a local physician. And so that's been a bit of a challenge, and that's why we talk a lot about partnerships, because you want to make sure that you've got somebody in your community, a physician, that will sign that local standing order for you so you can actually make that purchase. The manufacturer is requiring that you have that. So I just want to change the tune here. I was talking about community-based harm reduction programs, but I want to talk about the sequential intercept model. Not sure who's familiar with this, but it's a fantastic framework in which to really think about the programs that you have. The last one talking about the mental health collaboration, this sits right in this framework. And if you're already a stepping up site, which means that you're addressing mental health issues in your jail, this probably resonates with you, but we like to think of it in a framework for people who use drugs too. because there's all types of intercepts and points in the criminal justice system in which we can identify people who have an underlying substance use disorder and really try to treat them for that and not just incarcerate. Because the thing is, the reality is, if we take them to jail and they sit there for a couple days or a couple hours or a week or two, we haven't solved the underlying issue, and that's the substance use disorder. And so we talk about officers getting tired of doing the same thing and seeing the same people and going to the same house. This is one of those opportunities where we can really think about who our partners are in the system and who we can partner with to really design programs that will address these issues. One of the first programs that sits in the sequential intercept model, avoiding the entire criminal justice system, is one that's dear to my heart, and that's the LEAD program. Chief Bill is going to talk a little bit more in detail about it with you. But pre-arrest diversion, it utilizes officer discretion. Again, we're looking for individuals who have an underlying criminal or underlying substance use disorder, and that's why they're engaged in the criminal justice system. What's great about the LEAD program is that these stakeholders are already at the table. There's law enforcement, there's the district attorney, there's the treatment providers, hopefully there's harm reduction, but it's about getting all these people to the table to develop a program that will really make an impact on our criminal justice system. So you can see it's really growing across the nation. The National LEAD Bureau, Support Bureau is a great resource if you want to learn a little bit more about this. There is fidelity to the model. It sits in a harm reduction framework, and what that means is there's no compliance and there's no sanctions in this program. We realize that people who use drugs, it's a complex issue. Just because you get them into a program, you can't expect that everything's going to be great 4 days later or a week later. You know, this is a process. It does take time, and so you have to be understanding of that and make sure that you've got harm reduction strategies to keep them alive while they're on this journey. So we have 7 LEAD programs in North Carolina. What I want to point out to you is recidivism. This is a big piece of getting people engaged in treatment services, people who are typically involved in the criminal justice system. So what we're seeing in our LEAD sites where we have crime analysts and they're running criminal histories on a consistent basis, we're seeing that 80% of our participants are not having any more criminal justice activity. It's huge. It's really big. And so when you think about when we can get people into services, we have a higher level engaged in services, maybe hopefully we expect to have a lower engagement in criminal justice involvement, right? Because we're actually addressing the underlying issue. I want to move on to jail-based education. So when we think back to the sequential intercept model, think about our individuals who are getting ready to be released into the community. Research on North Carolina prisoners said that those exiting the prison were 40 times more likely to die of an opioid overdose within 2 weeks of release than the general population. That's a huge number, right? So we got to think about how can we prepare these individuals for their exit and how can we make sure that they're safe. And so we have created, or we've actually been implementing in a couple jails, Durham, we've been in Wake, Vance, and New Hanover County, and we provide this harm reduction based education to the individuals in the jail, and we make sure that prior to exit in their property, there's a naloxone kit. And we make sure they know how to use it. They have instructions on how to use it, and we also include a resource kit so that when they do exit, there are resources that are available to them. We have a peer support person who's involved in 3 new jails. That's in Cumberland, Catawba, and Haywood. And those programs, we have the naloxone distribution. We've actually created a curriculum that we would love to share with anyone who's interested once it's finalized. And we also have a best practices for jail administrators. That way, so when you're implementing this program, you've already got some tips and some best practices and challenges that we've experienced that we want to share with you. This is really one of those opportunities when you're in the facility to really engage with people in a compassionate, non-judgmental way and prepare them. And so we have a pre-post survey, and we've heard some great things from the individuals. They just say, hey, I'll call you as soon as I get out. I mean, think about it. Instead of just saying, hey, open the door, you're gone, here's your property. We actually have a peer support specialist who's already engaged with them and says, hey, when you get out, if you need something, here's my information, call me. We've also had individuals who have learned about naloxone and said, hey, I'm stuck in here and I'm worried about my loved one because they're an active addiction. And so I think they need naloxone where you make sure that they have a kit and they know how to use it. And so we're really helping them in so many ways. It's that personal connection. Syringe exchange services, I only bring this up because this continues to be something with law enforcement that training, I think, is still lagging behind. It was part of, let's see, back in, I think, 2017. It came out, but then I think there was maybe only a paragraph about it. And so maybe it was a selected topic, but we really need to circle back around this and make sure that people understand the general statute. So it's 90-113.27. And what it does is it legalizes syringe access services in North Carolina. And so anyone who is in possession of any of the materials that they've gotten from a syringe exchange are immune from being charged or prosecuted for those supplies. And I want to point out to you the images at the bottom of the screen are different types of syringe exchange cards. So what happens is we get calls from participants and they'll say, oh, law enforcement pulled me over and I had some used syringes and they said that my card wasn't valid, and they rip it up. And so we're like, okay, maybe we need to make sure that everybody knows that these cards may be looking different. And so here's 3 examples of cards here for North Carolina. It could be on a piece of paper, right? As long as it's authorized and it's got the name of the organization that issued it. If you're not familiar with syringe exchange, this is a portal to services. 1 in 5 people who go to a syringe exchange service, people go to syringe exchange services are 5 times more likely to enter into services. So if you think about how complex and how embarrassing and how judged people feel when they're actively using drugs, and how financially difficult it is to access services, they can go to syringe exchange, and the first thing that someone's going to say to them is, I'm so glad you're here. I'm glad you're here. How can I help you? Do you need naloxone? Do you need a referral to services? Do you need clean equipment because we have biohazard concerns? We want to reduce the transmission of HIV and Hep C. This is a place that people can go and not feel judged. And so as you can see, we've got 31 active syringe exchange sites in North Carolina, and it's growing. The last thing I want to talk about is OD MAP. I've got my friend Scott Higginbottom in the audience. Can you raise your hand? Scott is the contact for OD MAPs, and the reason I wanted to talk about this is that this is a free software for law enforcement. It was developed by the Baltimore HIDA, and what this does is it provides real-time surveillance data for fatal and near-fatal overdoses. And so what this means is when your officers or your deputies are out in the field and they take a report and respond to an overdose, they can either manually put it in the system, you can maybe have your victim advocate or your admin people put it in the system, or you can backdoor your system if you've got that platform and have it automatically uploaded. But what we're looking for is real-time information. So I showed you those maps earlier where they were 30 days, right? So ED visits within a 30-day period. But what if you could use this system and if you had, let's say, 2 or 4 overdoses in a 24-hour period, you would actually get a notification at your agency. And then you would know, that's called a spike alert, you would know that something was going on in the community, and this was a great opportunity for you to reach out to your public health, your harm reduction folks, and really make sure that the community knows that something's going on. So I think this system has got some great value to it. Like I said, it doesn't cost anything. If you're curious about it, Scott is your guy. He had some information on the table out front. When I talked earlier about law enforcement reporting naloxone use to our agency, and I said the numbers were not accurate because it's somewhat self-reported, OD Maps is a great platform in which we can know how many administrations are actually going on through the state. And that's what helps us justify getting more naloxone to give to law enforcement for free. But I think OD Maps has got a lot of opportunity for you to use data with your public health officials and design and tailor programs that can really benefit the community. They also have a text alert, which I thought was really interesting. So individuals who are at risk for overdose can sign up for your system, and they'll actually get an alert from the public health partner, whoever it is that you're partnering with, to know that there's some bad stuff out there. Because the thing is, people don't want to overdose. People don't want to die. They don't know what's in these drugs. And so we have to help people navigate this system. Okay, so here's my contact information. I know I had to fly through a bunch of that, but if you have any questions or if there's anything I can do to assist you, please connect with me. My email's on there, and also our agency website.
I know that the people in this room know that the opioid crisis is not something new. In fact, I was talking to a couple colleagues earlier and said, you know, what new can you tell me about the opioid crisis? With everything going on the news today about coronavirus and everything, on my way over here, there was a big story about the opioid crisis and how it's affecting people across this country. Is there any community here that's not been affected by the opioid crisis? Didn't think so. When we looked at this, when we started looking at this over a dozen years ago, we knew that it was a big problem in my community. I'm going to talk about that, but the CDC is always a couple years behind, but the last figures that they had, talking to Chief Parrish in the back of the room about the Vietnam era, when we talk about in that 20-year period from the first time that we sent advisors into Vietnam till that last helicopter flew out, little over 58,000 U.S. soldiers died in that war. In 2017 alone, in the year 2017, more than 72,000 people died of a drug overdose, with the majority of those being an opioid overdose here in our country. When we looked at it in our community again, more than a dozen years ago, it was an epidemic. And again, we hear about the coronavirus, and I just looked it up with the CDC. They're not calling it an epidemic. It's an outbreak. It's really got to be a serious issue for the CDC to come out and say an issue is an epidemic. The last time before the opioid issue was Ebola. Everybody can remember the seriousness of Ebola. Well, about 6 years ago, the CDC said this is not only an epidemic in our country, but it's the worst epidemic than we have ever seen in the country. So in my community, a dozen years ago, 1 out of every 4 people were dying of an opioid overdose. So when you look at heart attacks, fires, car crashes, heart disease, whatever it was, 1 out of every 4 people in my community died of an opioid overdose. Whether you're a Chapel Hill fan or a State fan or a Duke fan, it's number one. It's great to be number one, right, in basketball, football, or baseball. But when we looked at these heat maps, we were looking at my community, Waynesville and Haywood County, as the number one place in North Carolina as far as the death rate due to opioid abuse. So we knew that we had to do something. And just what is our role as law enforcement? You know, Colonel McNeil was up here earlier talking about the mission of the Highway Patrol in 1929 was to make the motoring public safe. Okay, he said their mission really hasn't changed. What is the mission and role of local law enforcement? What has changed? That was 90 years ago, and their mission is kind of the same thing. Has the mission and the role and the responsibilities of local law enforcement changed in 90 years? I'd say. You know, I started driving a patrol car in April of 1984, and, you know, 1 Adam 12 and Dragnet, Just the Facts, you know, James Q. Wilson, we were there to maintain order and to enforce the law. That was pretty much our job, right? The public didn't expect too much more out of law enforcement other than that. You know, there was this guy out, Daryl Gates out in Los Angeles, talking about DARE and putting cops in classrooms, and that was just out of the blue. You know, that's just way out of the paradigm. We just didn't do things like that. What are the roles and expectations of law enforcement today? Have they changed? Hey, does the public expect more out of us? And that's what we looked at a dozen years ago as a chief or as a law enforcement agency or a sheriff. You know, what was our role and responsibility in this opioid crisis? Because again, when you've got 1 out of every 4 people in your community dying due to something, and they talked about earlier in policing in rural communities, it was a little bit different from us because, you know what? We knew these people. Okay? When we responded to these calls and that 18-year-old kid was in that bathtub with a fentanyl patch on their arm and one hanging out of their mouth, we knew that kid. We knew their mom and dad. We knew that kid that had had surgery due to a soccer accident or had a dental procedure done, got hooked on pain pills, and now he's breaking into doctor's offices, stealing fentanyl patches and chewing on them. Okay, it was personal for us. We knew these kids. Dr. Rainier talked about the realities of the job, and that was our reality. So what we started to do, what can we do as law enforcement? And again, I know this is very basic for a lot of people, but when we talked about earlier about what we wanted to talk about today is we're going to start with the basics and just talk about those community partnerships and what can be done. The first thing we need to do is educate the community. And again, we're talking a dozen years ago, but does the community fully understand the opioid crisis today? Okay. We still have relatives, we still have people that go to the doctor, go to the dentist or whatever, and they'll take it, they'll get a refill, they'll get another one, and expect we'll be fine. Okay, do they understand how addiction works and how opioid addiction works? We had to not only train the public, but we had to train ourselves. It's very important that we as law enforcement officials, that we understand the evolution. Is the opioid crisis evolving? Okay, when we first started looking at this a dozen years ago, it was pain pills. Okay, that was pretty much all we dealt with. We didn't have heroin in my community. Nobody had ever even heard of fentanyl unless it was in a patch. But that was kind of all we had. I could brag to my buddies back where I used to work dope, we don't have heroin in my community. Okay, 6 or 7 years ago, that changed. Again, it evolved. If you can buy a bundle of heroin for $25 on the street and you're still paying $1 a milligram for a pain pill, guess what? It's a matter of economics. We now have heroin. We now have fentanyl. So we've got to stay up on the local and the national trends on what's going on there. We had to identify those stakeholders in our communities. Who are our partners and who should we work with to help stop this crisis? The slide up here shows some of the groups that we worked with. One of the most important groups on here is the schools. Melissa talked about seatbelts and harm reduction. When we were kids, most of us, when we got in a car, did anybody put a seatbelt on? We were riding in the package shelf, remember? You know, we'd riding in the back of the truck, whatever the case may be. My kids never got in a car without buckling up and telling mom and dad to buckle up. It's a matter of educating our children. So we thought it's very important that what kind of partnerships do we have as law enforcement with our schools when it talks about drug education. We've always had DARE, but are we doing anything in DARE with this opioid issue? Our schools, we're very, very fortunate where they invited us in every year in every middle school and high school throughout our county. We're able to come in and talk to them about the opioid crisis and what that means. It was kind of eye-opening. The first couple classes that we did, we had 12-year-old little girls in middle school coming up to us and crying and saying that they would go into mom and dad's medicine cabinet, take a Valium or Xanax, crush it up and snort it in the bus line every day. You know, we knew we were having issues, but we didn't know it was affecting those kids that young. We wanted to educate them, but the drug abuse issue was affecting kids as early as 11 and 12 years old. Our youngest overdose was 18 months. Obviously, they didn't intentionally overdose, but mom was using Percocet and morphine as a babysitter, okay? Putting them down the baby's throat, baby would go to sleep, mom could go do her thing. Actually, we were buying drugs for mom in the same house that baby died, okay? That little girl's picture still sits on my desk today to remind me of why we do what we do. We wanted to be big in community awareness. Again, make sure that your community understands opioid addiction. These are just some basic pamphlets that we made up, and every single opioid prescription that was filled in Haywood County got an opioid information pamphlet stapled to that bag. Okay, we had great luck with local pharmacies. A lot of the national pharmacies allowed it, some didn't. But try that. Go to your pharmacies. Make up. It's very, very cheap to make up these pamphlets to inform your public on what's going on. How many agencies here do pill take back days? Okay, you know, are they successful? Okay. Ours have been very, very successful. I thought, well, nobody's really going to bring their pills up to the local Ingles store or up to the local Publix or whatever. People bring them up in trash bags. We have 55-gallon drums in the back of trucks taking this stuff back to be incinerated. So pill take backs, even though they've been around a long time, they take a lot of pills off the streets. Agency drop boxes. How many agencies have drop boxes in their jurisdictions? Okay. We started putting these up. We've got 5 of them currently in a jurisdiction. I thought that we'd be emptying these things probably, you know, a couple times a month, 2 and 3 times a week. We're emptying. I'd come in the office at 7:30 in the morning and there'd be people lined up on the curb waiting to drop their pills in these boxes. So they're effective. They take a lot of pills off the street. I think the SBI, they keep records of that. And I don't know what those numbers are, but they used to keep pill counts. Now they keep tonnage. That's the amount of pills that are coming off the street. Anybody seen a MedSafe or a lockbox? Okay. About 13 years ago, we got our first grant through Project Lazarus for these lockboxes. We found that if people have access to our homes, they have access to our drugs. Okay. We looked at and we found, just like that those 12-year-old little girls, we as parents and we as grandparents had to understand that we have now become the biggest drug dealers for our kids. Kids don't have to buy these things out on the street. They get them from mom, they get them from dad, they get them from the grandparents. Okay. 58% of the pills obtained by people under 18 comes from our medicine cabinets. Okay. That's another reason why we don't want to do these pill takebacks. Okay. How many times have you gone to the dentist and they say, well, here's 30-day supply of pain pills for that filling we just gave you. You may or may not take one, but that pill bottle sits up there because, you know, you might fall out of bed and injure your knee one day and you may need one in the future, right? Does that ever happen? But those pills still sit in that pill box. We used to work unattended deaths. I'm sure y'all have been there. Okay. All of a sudden you look up and family members are down the hallway waiting for you to leave, right? They haven't come seen grandma in 10 years, but now the grandma's gone. What are they there for? The pills. Okay. We used to have if some of the drug dealers or drug people in our community put as much effort into a job as they did with some of these other things, they'd be very successful. But why would somebody read the obituaries every day if you're addicted to these pills? Right. Okay. Go down, find out which obituary says in lieu of flowers, contributions can be made to the American Cancer Society. We see it every day, right? Well, so the person after those pills says, well, if they had cancer, good chance there's pills in the house. The service is Friday at 3 o'clock. Okay, the family's going to be at the service. We're going to go break into the house. So again, we want to do what we can to safeguard those pills. There's grants out there. We got them through our local hospital grant. There's all kinds of ways. People that shampoo our carpets. My wife's in real estate. Okay, somebody calls up and says, I want to see 6 houses. My wife's in the kitchen showing Mrs. Jones all those new stainless steel appliances. What's Mr. Jones doing? I'm gonna go check out that master bathroom again. Okay, looking for pills. Again, we need to educate our community in what to look for. Safe needle disposal. What in the heck is law enforcement? Why are we as police officers involved in needle disposal? This isn't syringe exchange. This isn't anything about that. I had a detective who had been out to Seattle come back and said, you know, I've got a grant for these needle disposal boxes. I said, great, send it to the health department or something. That's not police. We don't do that kind of thing. Okay. But how many calls for service do you hear or go to yourself where you've got that 3 or 4-year-old little boy or girl coming out of the bathroom at the Burger King holding dirty needles? Okay. It was happening repeatedly in my jurisdiction. It still is occurring in my jurisdiction. So we did what we can to help with that. And of course, when we got this grant, I said, well, you know, I'm the chief, I'm the smart guy. Let's put it at the fire station. Let's put them in the back of the PD because they're bringing pills to the PD. Well, they'll bring their dirty stuff here. Okay. I had somebody from the street come to me and say, no offense, but you're crazy. They're not going to bring dirty needles to the PD. They're not going to bring them to the fire department. Where there's a 99-cent menu, that's where you need to put them. In the bathrooms of the Burger King, of the McDonald's, of the fast food restaurants. I had a guy come to me who had been in that community, the drug community, for a long time. He said, call your local plumber. I said, why are we calling our plumber? He said, because the repeated responses by the plumbers to the locations where needles are stopping up your commodes, that's where you need a needle box. Okay. So that's what we did. We called the plumbers, and lo and behold, when we looked at our response locations, it matched where the plumbers were responding. Every city facility, every city park, and we didn't have to install them. My city, the Public Works Department says, you identify where they're going, we'll go out and install them for you. So it worked very, very well. Melissa talked about naloxone and patrol. And I probably don't need to see a show of hands, but is this controversial at all in your agency as far as police officers or deputy sheriffs carrying naloxone? I mean, I've heard it. My son-in-law is a police officer in a city here in North Carolina. He said, you know, the officers on the street hate it because, you know, we've done it 2 times, 3 times with the same person. And, you know, we're just not into that. We're not EMS. Okay. We looked at it as soon as the Good Samaritan law was passed. We looked at providing naloxone as a tool, as another resource for our officers. Again, it was hard to go to that scene when that 19-year-old is laying there. You know, the 19-year-old's parents, you know how they got in that position to stand by and helpless waiting for EMS to get there. So we were the very first county that every single law enforcement agency or every single law enforcement officer in the county was equipped with naloxone. Okay. It's just another tool. We look at it as another. We carry first aid kits. We carry tourniquets. We even carry AEDs in the car. Okay. We don't go to somebody and say, now, how did they get in that position? How did they get in this situation before we administer first aid? Okay. We look at it as if somebody's in need of life-saving measure, we have the tool, we have the resource, we're going to do it. As far as those repeat individuals, we've got people that have, again, carrying AEDs in the cars. If they come to the same individual and say, well, I've already administered an AED to you, and about a year ago, and in the meantime, I've seen you at the Wendy's still eating cheeseburgers, I don't think you deserve to be defibrillated again. We're going to move on. Okay. As a chief, as a sheriff, as an agency head, as an officer, should we have the discretion to say, we're going to administer life-saving first aid to you or not? We look at it as, again, it's another tool to help save a life. When we looked at those partners, the hardest individuals to get to the table was the medical community. Again, I wore a blue shirt and a badge, and I'm not going to tell somebody how to prescribe medication. That's not what we were there for. But eventually, we did have a group of physicians, most of them were cancer doctors, that came to us and says, we want to help. So we started an organization called PROP, Physicians for Responsible Opiate Prescribing. We got grants where we had blister packs with acetaminophen and ibuprofen combinations, which were as an effective pain reliever as an opioid, but it wasn't addictive. So we were going around and passing these out. We didn't. The physicians did. Go to other physicians, dentists, and give them this resource again to provide pain relief for the community without getting them addicted to pills. We've all heard of the STOP Act, the HOPE Act. It's going to take, and it has taken, good, effective legislation to help curb the crisis in our state. Since the STOP Act and the HOPE Act have been passed, those numbers are, for the first time ever, have started to decrease in the state of North Carolina. Years ago, we were in the top 3 in the state for meth production. It took good, effective legislation as far as how you can get ephedrine and pseudoephedrine, take it off the shelf, put it behind the counter. You got to sign for it. You can only get 2 boxes at a time. That stopped meth production in our county. It didn't stop meth, they're just coming down the interstate, but it stopped the production. We look at good, effective legislation like the STOP Act, which regulated the prescribers, and then the HOPE Act, which gave tools to law enforcement. And one of the big things that the HOPE Act gave to law enforcement on the local level was it gave our local drug agents access to the controlled substance reporting system. There's the law enforcement officers here in the room. Do you have agents in your agency that have been trained in the use of the controlled substance reporting system? That training's available. Okay, the SBI is doing that. You do not have to go through an SBI diversion agent any longer to have access to the CSRS. Contact the SBI. There are classes of the Justice Academy. I believe, Trevor, is there another class scheduled on that? Do you know? September? Okay, September. That gives access to your people, your drug investigators, to the controlled substance reporting system. Melissa talked about LEAD. Again, we were looking at ways to think kind of out of the box on what we could do to stop this problem, stop this cycle. And we saw people again, we knew the kids, we knew their families, may have gotten addicted due to a medical procedure or at the dentist or whatever the case may be, but we saw that they were out here committing low-level crimes solely for the purpose of fueling their addiction, okay? How many people, does anybody have a prosecutorial district here that everybody that goes into the court system provides substance abuse treatment, provides everything they need so they don't reoffend. Anybody? We certainly weren't in that category. So we looked at things that we could do to help break that cycle of addiction, because if we broke the cycle of addiction, we broke the cycle of criminality. And that's what Melissa was talking about in recidivism. And the thing we liked about, we went out to Seattle, had a detective go out there and look at their lead program. When she came back, said it'll never fly in Haywood County. It'll never fly in rural Appalachia, in rural North Carolina, in a mountain community. It's just not going to work. You're not going to go out here and sell drugs and then be put in a treatment program and not face criminal prosecution. But the good thing about the LEAD program is it allows us, or any agency, to develop their own criteria on who is eligible to go into that program, that treatment program. Fayetteville was the first in the state. We spent a lot of time working with Fayetteville, but I tell you, what was acceptable to the Fayetteville community was not acceptable in Waynesville. You know, they had a certain possession amount that you could possess up to 4, 5, 6, whatever grand. That's not going to go in Waynesville. But we developed our own criteria. We sat down with the district attorney. We sat down with partners in the community and said, let us develop our own criteria. If you sell drugs, if you victimize somebody else, you're not eligible. You're going to straight to the criminal justice system. In other communities, they said, well, we can work with that. It would never fly in my community. But low-level crimes are shoplifting. They're a small amount of possessing a small amount of drugs. We felt like, again, if we could break that cycle of addiction, we would break that criminality. We have 2 ways that you can get a referral in the LEAD program. First is charge diversion. That person that was shoplifting to sell the TV, to buy some pills or whatever, again, that's a charge diversion. It is at the complete discretion of the officer and the victim on whether that person goes into the program or not. So again, it's the criteria that our community came up with. The other is, which we've had more success with, is social referral. Anybody familiar with the HOPE initiative in Nashville? Chief Tom Bashore came up with an initiative where anybody that walked into the Nashville Police Department that said, I need help, I need treatment, my son or daughter needs treatment, we're here for it, they would find treatment somewhere in the community. That's basically what the social referral is built around. If somebody comes in, an officer knows somebody that's sleeping in a cardboard box that is facing this addiction issue that's really not causing anybody any harm but to themselves, they can bring them in and say, we want to refer them to treatment, and we'll get them into treatment. On the charge diversion side, once that charge is diverted, then they have a mandatory time frame that they have to meet with the lead agent to make that charge go away. This is just a form that we came up with as far as the criteria on what, and here's the list of referral charges right here, and in red obviously is a disqualifier. The other issue that we had was on probation. We had to meet with our probation officers to make sure that they were okay with the criteria that had been set. The next thing that came out of the LEAD program is an overdose recovery response. How many people have a non-fatal overdose response team or program in your agency? Okay. Every time we have a non-fatal overdose, whether they go to the hospital, when they return to the house, or if they're left there at the house, we have a team that goes out and meets with those, and I keep saying we, the agency I used to work with at Waynesville, and Haywood County is participating in this as well. A team would go out comprised of law enforcement, harm reduction, and mental health, the substance abuse treatment people, okay? It may or may not be willing or ready to get treatment, but we provide resources to let them know where to go to receive substance abuse treatment in the future. All of our responding officers of those fills out this overdose response report for 2 reasons. The first, obviously, is to try for follow-up, to get them into treatment. The other is for investigative information. Mr. Locks is going to talk about some of those trends and tools that we can use to investigate. When a loved one's laying there on the floor, the friends, family, whoever it is more willing to tell us at the time of where they may be getting their drugs. Is it still our responsibility to go out and find where the drugs are coming into our community and who's bringing them in? Absolutely. So this overdose response report is twofold. Again, find treatment, help people out, but also to find out as an investigative tool who is bringing drugs into the community, who is sold to this individual, and where. Some of the things that where do we go from here? Hope mentioned the Attorney General's Opioid Task Force. This is just some of the things we're working on, again, in red. Please, if you don't have your local investigators and detectives trained in the use of the CSRS, please do so. You can talk to Trevor and Mr. Laux about those upcoming classes with that. The other thing that I would love to see is we talk about the CSRS is a great tool. It can show us who is abusing opioids. The problem we got where we live, we're surrounded by 4 states. Within an hour from Waynesville, you can drive to Virginia, Tennessee, South Carolina, or Georgia. Okay, the databases don't connect. Okay, so we've got people doctor shopping all over in 5 states, and we can't track that. So we would love to work with the new the President's Commission on Opioid Abuse to try to kind of take care of that and to fill that donut hole. So I appreciate your time. I know we kind of rushed through that, but if there's anything we can do for you, there's my phone number, and I have cards as well if after the meeting. Thank you.
Again, my name is Bill Laux. I work with the Justice Academy. My areas that I specialize in are narcotics and gangs. Retired previously from Metro Nashville, Tennessee Police Department, which happens to be the 24th largest city in the United States. So when I look at some of this intel stuff and some of the stories that we've seen here, even with that city and that population, that jurisdiction, it's the same all the way around. For us, in my experience level, 2013, particularly May of 2013, is when this epidemic hit us hard, when we saw it firsthand in Nashville, Tennessee. When I say it hit us hard, we started getting calls from the various hospitals. And there's not 1, not 2, not 3, not 4, but there's 9 hospitals in Nashville, Tennessee. Hospitals would call us and say, hey, we've had 9 overdose patients show up to our ER in the last 2 hours. Okay. Bosses come to us and say, drug guys, go figure this out. We're like, okay, this is new for us. We're used to going out buying the dope. Our end of intel was stemmed from if I knew John Smith was selling at 12 Hazel Street, and during my first undercover buy, I watched John Smith leave the front door, 12 Hazel Street, drive to meet us, sell us drugs, and come back, get out of his or her car, use a key, enter the front door, and walk back in the residence at 12 Hazel Street. That was a piece of intel that I used to forecast for what I needed to do for buy walk number 2, to develop additional probable cause, to make sure that my search warrant is suppression proof. So now when I go to buy number 2, I put more resources in there at 12 Hazel Street to look for Mr. Smith leaving the residence to come to us. But with us, we were faced real time with going to the hospital, and as we're standing there, NFD, the fire department, is bringing in multiple more people, and we would see it in chunks of area throughout the county. We sat down and was like, how do we deal with this? So we had to wrap our heads around together, because for that month, all the narcotics elements, we worked approximately 16 hours a day, 7 days a week. There was times I was sitting at the hospital interviewing 12 people, patients that have been successfully revived with Narcan, which for us, we started learning was our telltale sign of, okay, this is an overdose. This is an opioid-related overdose, just like our field tests get out there. We know the problem. Then we started interviewing these folks and getting the common denominator, saying, hey, what is the common denominator here? And they would sit down, hey, I'm buying heroin, brown tar heroin, China white heroin, these particular guys. So this started making sense into our particular, why it was happening in cluster areas versus all over the city. Our next step was, okay, who you buying from? We'd start collecting that intel, start looking at their phones, seeing if they would give us information on the dealer. Most of the time they would sit there and look at us and go, nah, it's okay, it's all right. And I sat down and I was like, when you were brought here, you were dead. Your respiratory rate was approximately 1 breath a minute. I'm not a doctor, but you're close to being gone. And they looked and said, well, yeah. And I said, why is it? Why are you okay with that? And they said, well, the ultimate high for an opioid user or somebody hooked on this is to get as close to death as possible. And to me, it hit home. I was like, oh my God. So we started having to figure out how we started finding common denominators with the dealers. We started having to go back and look at things like our phones, doing cell dumps, cell tower data reports, CDR maps and stuff. These are investigative tools that we were using to figure out who was in the general area while this stuff was occurring. Our end takeaway from this was it was happening so fast. By the time I would get done interviewing 9 to 12 people before I could leave, and I've been there approximately 7, 8 hours, another 5, 6, 7 people were rolled in. And 2 or 3 of those didn't make it. We thought, why is the heroin killing all these folks? So now we have to start looking all the way around and trying to figure out, okay, people are snorting it. Some people are injecting it. Some people are smoking it. We still couldn't find that overall common denominator except for the powder heroin substance at the time. We got our crime lab involved because we had our own crime lab within our agency. They started taking the products immediately and started sticking them up on their gas chromosome mass spectrometers. And all of a sudden, that's the first time we started hearing fentanyl coming to the arena. 90% of all of those samples that were coming in immediately were fentanyl derived. We sat down and went, okay, we got a problem because now this is a unique response for us as far as law enforcement. It didn't affect just the police too. We talk about relationships and partnerships here. At the same token, our paramedics, our fire folks, the guys and gals that are responding to the car crash, somebody hit a telephone pole at an intersection. They responded to a person of being unresponsive in the parking lot, in a car at Walgreens, backed in. And they'd get up there to the car wreck or that unresponsive person, and they would open up the door, and the first thing they would see is a syringe in their arm or a syringe in their immediate grasp area. Then they came to us and said, why are we seeing this? We was like, we're seeing this now also. This is a fentanyl issue. So we had to partner up together and say, you know what, this is 1, a hazardous substance. 2, while we're dealing with this, we have to have on some sort of PPE. Drives us into another arena. Most police don't like to hear PPE structures, but there's certain guidelines out there that tell us what we have to wear. But our takeaway from this is contaminated locations, resources. When police are responding to overdose locations, they have to understand if they walk in the door and somebody is standing there and they've still got their arm tied off, they've got a needle stuck in their arm, the plunger's only halfway down, our first thing shouldn't be to go up and start taking a look and start taking pictures of it and stuff. It's time to back out, start putting on N95, some sort of respirator, some sort of respiratory protection, ventless goggles, some gloves. These are cheap items. All 3 of those items right there, I can outfit somebody for about $8.84, essentially, per person. But on the backside, we couldn't get our head wrapped around it. We were like, why is this hitting? Why is this hitting so fast and so hard? Well, I'm also an associate board member for the International Narcotics Interdiction Association. So I start making phone calls to guys and gals in California, New Mexico, New York, here in North Carolina, Florida, Michigan. And they was like, this has hit us the same thing, same way. So we sat down and was like, how do we collect this intel? How do we look at these pieces of intel and what is intel? Well, first of all, to understand how we even need to collect this, we need to look at what brought us here. Because if we understand what brought us here, it's going to help us effectively forecast in the future what direction this is going. So we understand as we're putting these modules together, as far as bringing people in, getting counseling and services, when we come to that fork in the road, do we need to turn left or right to try to stay ahead of it? When I say try to stay ahead of it, we're not. But we're effectively trying to catch up and we're understanding a little bit. So first thing, if we're navigating the course all the way around, we got to look at our first thing. Oxycodone came into place as a result in the 30s. And that product hit the market that maker did not know and or understand that when oxycodone came into effect, that theoretically 80, 90 years later, that this would be one of the larger epidemics in United States history. When I say epidemics, look around the room when I ask this question. This is to show how deep this is. Does anybody here not know an officer, a fireman, have a family member, and or seen a ton of responses in your community, or know of somebody who has not been affected by an addiction to anything opiate related? Opioids, oxycodone, roxicodone, hydrocodone, Lorcet, Percodan, anything. Anybody by a show of hands say you do not know anybody and or have never seen it? Not one hand has come up. When I say this is an epidemic, it's here. So how did it spiral into it? Well, our next step is it started hitting the market. We see the lawsuits, Purdue Pharma, all these other large agencies talking about they brought this stuff in. In the late 90s, it was marketed somewhat, I don't want to say illicitly, but I'm not an attorney, but I'm going to tell you it was marketed wrong. There's videos out there that show actual Purdue Pharma doctors sitting there saying, I repeat, word for word, this is the best treatment, best method for pain management, and it has the least risk of addiction. In most of our studies, less than 1% of our patients become addicted to this. I think you read that backwards. So all of a sudden, this hits the market. This is out there. We don't go into the overall schematics of addiction because we would be in the weeds here talking about how it affects the brains, neuroreceptors, all kinds of stuff. But our next thing is, okay, if we have this here, how does this fit overall within our population? So if you look historically, or by CDC numbers, NATO numbers, the United States accounts for approximately 5% of the world's population. 5% of the world's population. That number says, man, there's a lot of people in the world. I thought we were larger than that, but we account for that. So with that, we have to look at also that as 5% of the world's population with DEA's ARCOS numbers, the Automated Reporting Consolidation Ordering System, where the DEA keeps track nationally of controlled substances manufactured worldwide and where they're distributed, it shows that the United States is consuming more than 50% of all of the prescription pharmaceuticals manufactured worldwide. These are non-opiates. These are things like Coumadin, blood thinners, reflux medicine, Z-Paks, daily medications, inhalers, and histamines and stuff. That same report, though, 5% of the world's population were consuming more than 50% of all the controlled substances manufactured worldwide, also shows us consuming approximately 69% of all of the prescription narcotics manufactured in the world. What does that number right there say? Ladies and gentlemen, we're here. We're here. We're already behind. So when we look deeply in it, we're consuming approximately 99.1% of all the hydrocodone. Where is all of the hydrocodone manufactured basically for the world at? Wilson, North Carolina. Now, does this hit home? I'm telling you where one of these products is. It doesn't make Wilson bad. I'm just telling you we have it here. This is how close this is. We're eating up approximately 72.9% of all the oxycodone, and you can see the numbers, and these numbers continuously go up day by day. When we look at, as this started transpiring, then we started to see the pill mill epidemic. This played into us extremely, extremely heavily. Predominantly Florida, because they seem to be off the charts. When ARCOS Systems comes out and they started looking at it nationally, Florida led the way as far as this number started going. This is where we started seeing our doctor's offices like set up in old strip malls, in old places like that used to be a Subway restaurant or a Burger King, or a doctor's office where a doctor is meeting with patients at 6 in the evening to 9 at the local Starbucks. I've never got to go to my doctor's office at Starbucks. Occasionally, my doctor's office might have a sign up that says, we proudly serve Starbucks coffee, but that's about it. That's the closest I come to it. So when we talk about the Florida pill mills and stuff like that, how fast does this transpire? How fast does this get out there? Well, in just the first 6 months of 2008 alone, Broward County, Florida is responsible for prescribing approximately 67% of all of the oxycodone that was prescribed in the United States. That may not seem like a large number until you look at the fact that 5% of the world's population, we're consuming more than 50% of all the pharmaceuticals manufactured worldwide. We're consuming more than a little bit over 67 to 68% of these opiates, narcotics. In one county alone, accounts for 67% of that number also. What does that say? Like Chief talked about, that's where our doctor shoppers. He's bordering 4 states. We saw the same thing in Tennessee. When we would see pill mills, even up to the date that I would left, when I retired in 2018, August of 2018, we were still seeing doctors come up from Florida and try to set up shop in neighborhoods, at houses and stuff like that. And we would jump on them fairly fast. The other thing we were having problems with, we would try to take these doctors down, and we'd try to start looking at things like prescription monitoring profiles, the PMPs, patient records. The last time I wrote a search warrant to get patients' records from a dirty doctor, and I'm gonna tell you straight up, it was a dirty doctor. I know it was a dirty doctor because 1, I was doing the undercover to sit there. 2, when the odd doctor's office opened up at 9 a.m., I was there having to stand in line at 6 a.m. and I was already like 43 or 44 in line. That's a good doctor, I gotta tell you that. 3, somebody sold me an MRI while I was in line. There's another clue. 4, as we started looking around through all the patients in Tennessee, you could see the county that the vehicles registered to. Not one of those vehicles were from Nashville, Davidson County. They were all 3, 4, 5 hours away. Start seeing cars from Georgia, started seeing cars from North Carolina, started seeing cars from Kentucky. It was like, oh my God, this is happening fast. This is how fast this stuff comes in. So that's why these databases are important. We talked about the controlled substance monitoring database and stuff. I am the school director over that CSRS program. I work effectively with Special Agent John Keene, who is the special agent in charge over the Diversion and Environmental Crimes Unit with the SBI. We run that program hand in hand. So I will give information if you're interested in getting officers come out, because we do have another course coming up in September for us. So within the pill mill epidemic, we started seeing all the individual states start creating something, the equivalent of our CSRS, or some states call it a CSMD, Controlled Substance Monitoring Database, a PMP, a prescription monitoring profile, whatever it is. What that did was that started locking out some of these doctor shoppers, started taking some of the product away, but the addiction is still there. The drive is still there. Now it's just, where are these people going? So the next thing we started looking at here is, what did we do also on top of this? And some of this plays in, even if we try to take one level of way of an opportunity of somebody who has substance use disorder obtaining pills, once we put something in place and we start taking some of those folks out of that game, they're probably going to come back in a different arena in some venues. So we started looking at the STOP Act and then the HOPE Act. And the STOP Act, one of the biggest things was we did the right thing. We started putting some prescribing limits on what was going out the door. There's no need for somebody to have a root canal or a filling put in and a doctor writes you 30 days of Percocet. 3 days at worst, at best case scenario. So there wasn't nothing in there. So once we started restricting some of this, we also started seeing that folks that needed this stuff, people that actually have things like degenerative disc disease, RA, all these other kind of functions going on, or they've had car wrecks previously, they were injured at work and stuff like that. There was a necessity for this. So we started, the doctors weren't able to give them as many pills. So they started looking for an alternative resource. So the next thing we brought in was the HOPE Act. So this is where we get at a personal level, because North Carolina, and I will tout this as a beautiful thing, North Carolina is the pioneer when it comes to giving state level officers, somebody outside of the state jurisdiction at a local level, access to some sort of prescription records. Because in one of the incidents I was telling you about with the doctor shopping incident with the dirty doctor that come up from Florida that set up shop in Nashville, when I wrote the search warrant to get the patient's profiles, because we were trying to collect data as far as where they come from, what type of information was being given as far as what type of ailments were they saying and stuff. I walked away with a 57-page long search warrant. It took me effectively 2.5 days to write it. It took a judge almost 36 hours to go through from the time I delivered it to her, for her to look at it, for her to call me back and say this exact words. I can see where you're going with this. But she said, HIPAA, I think, still precludes and doesn't allow you access to this. I can't give you the search warrant. And I sat down and went, oh my God, there's a protection measure. What we're trying to do is take the source away. We're not trying to remove the folks that have the addiction. We're trying to take the doctor, the people that are preying on these folks that are already deep, that need help. So here within the HOPE Act, it gives local officers access to the controlled substance reporting system. It is a commission course. It is a certification course in their specific things. It's one of these, hey, we're a pilot program. We're the first ones nationwide, essentially, that have this access, that gives officers outside of a state bureau of investigation some sort of access to this. That's a beautiful thing. We are leading the charge in that. That statute alone is powerful. But what that also does is we're also able to capture and cut off doctor shoppers. But what do we have there still? We still have the addiction. We're still limited in our resources, so what do they start looking at? The alternative methods to getting this. And what's our alternative methods? The cartels. More in depth, Arellano Felix organization in Sinaloa. A lot of people sit down and say, well, the cartels, yeah, they're dealing with heroin and stuff like that, but why? Well, when the pill mill epidemic started hitting, we started looking at this. Out on the streets in 2010, we started seeing into the midsummer, spinning into 2011. Cocaine started to become less prevalent. Our informants would come to us and say, hey, I can't buy an ounce of cocaine from this guy anymore because he said he's out, it's dry. Where if they had an ounce of cocaine, instead of it being $800 to $1,100 at the time, now it was $1,500 to $1,600. We was like, what is going on? Did we finally knock off all the cocaine in Nashville? So again, we picked up the phone with effective partnerships, started calling people, Atlanta, New York, Detroit, Los Angeles, Philadelphia, and they said, nope, we're seeing the same exact thing. So we go to some training in 2011. Part of the training is a cartel lieutenant, former cartel lieutenant who is finished up on the backside, is still under the alias, under witness protection, tells us, and he's Arellano Felix organization cartel lieutenant. He gives us the breakdown of this. He said, look, he said, you guys see your increased productions or your increased supply of meth out there, predominantly crystal methamphetamine. It's like, absolutely. Do you see cocaine going down? We was like, absolutely. Do you see heroin becoming more prevalent? We was like, God, yeah, actually our seizures are up about 2,000%. And he painted the picture why. And from a business perspective, and he said it just like that, he said, from a business perspective, it made sense. We thought, what do you mean? He said, think about it. Cocaine comes from the coca leaf, grown in Peru, Bolivia, Colombia. It's processed by, that's where it's mostly grown, in those 3 regions of the world. It's processed by cocaleros. It's converted into a cocaine paste by the Colombian cartels. Colombian cartels then sell it to the Mexican cartels and the DTOs. Mexican cartels and DTOs then convert it into a cocaine HCl, cocaine hydrochloride. Then they push it up to the various DTOs, finger extensions, and hits the United States. They said, but here's what happened. We're paying Colombian side for this. At the same time, our folks on the street are looking at and hearing the request for people wanting pills prescription pills, oxycodone, roxycodone. And we sat down and was like, what do you mean your people heard that? And he was like, that's what our bosses would hear. That's what was coming down to the plazas and stuff. And he said, our research and development guys started keying in on this. And we thought, did he just say research and development guys? And he goes, yes, we have them. He said, this is a multi-billion-dollar business. We thought, God, this is huge. He said, their thought was, we'll start bringing in instead of the pills because you guys have cut the pills down, but your addiction is still there. So then our guys started pumping in heroin because they can cut out a little bit of the Colombian side, increase profits. It's cheaper, it's a longer lasting high. That's why you're seeing more of it in play. And we were like, oh God. 2013, we started seeing ODs started increasing. We're like, what's happening? And we started seeing fentanyl and stuff like that. 2015, through proper great networking, Eddie Dutchover, who is a Mwapa tribal reservation outside of Phoenix, Arizona, he's an officer out there. He conducted a roadside traffic stop with a guy, caught him with about $2.4 million. That's pretty good. I've got $9 in my wallet. That dude's doing something better than me, obviously. The guy was the money man for Ivan Guzman. Ivan Guzman is the son of Juan Chapo Guzman. This was after the third time we made the capture of Juan Chapo Guzman. He actually, during the roadside stop with Eddie, said, look, I'll work for the government. He said, I'm here because our organization's in a tailspin. You guys have basically cut the head off the snake a little bit. We've got all these other factions fighting with us. And he tells the story that the AFO lieutenant did, even to provide video proof. This man had enough information and was so legit that within 7 hours, HSI actually had a plane landed, swooped him and Eddie up, took him to a different location and let them start working and stuff. This guy was providing video proof of cartel members in jungle settings in SCBAs, self-contained breathing apparatus. When I say SCBAs, I'm talking, I can tell you in depth down to, it was Scott brand SCBAs. 5X chem suits with like boat oars and sticks mixing in plastic bats and stuff like that, telling them, hey, we're putting in fentanyl into this stuff. Why? He said, because you guys have more of a request for heroin. It's going through the roofs. It's taken our cocaine profits and drove it up over 1,800% in the last 2 years alone. We're a nation fed by addiction. We're already there. So they're filling it in there. Now, you said they're wearing that stuff because they know it's going to kill them. We've lost enough people. We sat down and was like, oh God, if cartel folks are wearing this, then that creates another aspect. Why don't we as a responding officer why are we not wearing this stuff all the time? So for us to look at some of this, though, we've got to understand that as we're forecasting ahead, and yes, we're putting in services and stuff, but from the street side, and even when I've talked with the FBI and stuff like that, they said, every time we add a new piece into place to take away from the substance use disorder issue and try to get folks help, even though we get enough people in here to reduce some of this, like Chief also talked about, you heard some of those astonishing numbers, an 18-month-old, 12-year-olds out there. The epidemic's already there. The access is already there. So people are developing these addictions day to day. With us restricting some of this stuff, we're also seeing new overdose victims pop up. The grandma that never had a criminal history in her life, nothing ever went wrong, but she's had chronic arthritis or something, and the doctor's been feeding her pills for an extended period of time. Because she's falling under some of these prescription restrictions and stuff like that, now she's cut off. What happens? You're not going to go into withdrawals and just say, I'll shake it off. If you've been taking this stuff for 9, 10, 12, 13 years, what's the alternative? It's out there in the street. Doesn't make grandma a bad person, but we've got to forecast ahead and know that some of these overdose numbers are going to increase, and we're going to see new victims step into this arena. But this helps us overall look at, how did we get here, one? Number two, everything we've talked about here is a piece of intel. When she pulled up the charts there about the heat maps and stuff like that, is that not an effective piece of intel to tell me what is going on in my jurisdiction? Intel is not just my cell phones taken off of somebody who was found with a syringe in their arm to figure out the dealer and stuff. And you can make great cases with this. You do have to look electronically back because you're working basically from an overdose death, you're working a homicide backwards essentially. But we also have the new death by distribution bill that's coming to place too. That's removed the malice element out of this. So for a prosecution side, if we do this right, we can start taking some of these predators that are pumping this poison in there into our systems off the street and maybe give them a little bit of alternative too and say, hey, it's time for a change. You're not going to last out here forever. So available for any questions. Anybody has anything? I know everybody's like, man, he went deep in that, huh? So thank y'all.
All right, I'll open it up to the group. Are there any questions for our presenters? I actually have one for Chief Bill. You described a lot of innovative strategies that you use to address the opioid epidemic in particular, but I'm just wondering, as you think about maybe the next drug epidemic, whatever it may be, I'm just kind of wondering if you could speak to potentially some of the infrastructure that you've set up that will help your law enforcement officers handle the next drug, because the next drug might not have a reversal drug like naloxone, for example. So I was just kind of wondering if you could speak to that.
Well, obviously, I don't have an agency, but as police chiefs or sheriffs across the state, I think we have to prepare for that evolution on what is next. I can tell you that my community wasn't, even though we had been dealing with the pill crisis for years, we never had that heroin. So when heroin came in, it was fairly new to the officers in my jurisdiction. Then when fentanyl came in again and all the scares about, if you inhale it, this. So how many people have changed their policy when it comes to handling an unknown white powder when you find it on the street? Do we go back and field test it now? We've got to kind of adapt and improvise to whatever that quote next drug is going to be. Sitting here, I just got to update Governor Cooper. Different people are out here talking about new plans for a new virus. We've got to do the same thing when it comes to whatever that next drug is going to be. The fentanyl is an extremely deadly drug. And what Melissa was talking about, instead of we knew that if we hit them with Narcan once, when it was strictly an opioid, a pill issue, maybe even heroin, they were going to come back. We've had to hit people 4 or 5 times. I don't mean to say hit, but administer 4 or 5 times with naloxone with the fentanyl issue. That's what we've developed in these partnerships with our medical people, our emergency room. We meet with our emergency room physicians at our hospital every quarter to talk about the trends that they're seeing to come in. And we're just going to prepare for what that new drug might be, that we're equipped to deal with that and hope it's not as deadly as the last. I really don't have a great answer as far as saying what that next drug is going to be, but hopefully our officers and deputies will be prepared to handle or to deal with that next drug and also deal with that next, the addiction that comes with that drug.
Does anyone have any questions from the audience? All right, so I think there's a question in the back.
In training local law enforcement and drug and gang units, are y'all talking about the intersection of human trafficking and drugs and gangs, since it's very intertwined?
Absolutely we are. And again, here's a piece of intel. A lot of people sit down and say, well, is it true that gang members are actually selling people like human trafficking? When we think about human trafficking, we're thinking somebody from a third world country stuck in the basement somewhere in chains. I can tell you that that is not today's concept, okay? Even Fayetteville, when I've discussed them, and I'm not a human trafficking expert, but I've attended some training with them, and Paul Phelan deals with the human trafficking on our side. But they said they've seen soldiers locked in houses and sold for sex. and sold for services. If you think about this, if you're a drug dealer, if I go out and buy an ounce of cocaine, once that ounce is sold, I have to go out again to my supplier and re-up my commodity. If I have a person, a girl or two or three that I have out there working under me, and they're seeing 5, 6, 7, 8, 9, 10 people a day, they can keep going. I don't have to re-up that commodity. A lot of people are like, well, God, so are gang members actually doing this? Yes. A gang isn't just there to facilitate, hey, we're the biggest, best gang out there. What drives the train at the end of the day of all of this? Yes, I see 3 or 4 of you doing this. Money, 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 money. So yes, we're talking about it. Actually, we're developing some training, a new course coming up called Gangs, Guns, Drugs. And it talks about the intersection of how this is happening. People are making money all through all 3 venues and routes and stuff. Even our local gangs are distributing drugs. They're dealing with prostitution, human trafficking, stolen goods and stuff like that. But even the drugs, because they have cocaine here, doesn't mean they grew the coca leaf. No, the cartels have built these ties and these links. Unfortunately, they're doing like we're doing, networking, tying in other entities and stuff. That's how they're doing. They're bringing in gang members, organizations to actually work with them to get this poison out on the street, essentially. Yes, the end result is we are tying this and staying ahead of that and bringing that, because that is now moving up to probably the 3rd most prevalent type of profit from illicit stuff out there. Number 1, it was drugs, along with like diamond smuggling and stuff. Now human trafficking is stepping into the realm of number 2 of that. So it is a money making business. But yeah, we are definitely hot on that, trying to get into that deep, fast, and hard. So do you have something with that? Or?
Just in those officers that are involved with JTA, joint task forces with the FBI, that's something that we've been working with them on for a long time. I think Asheville area has been working with the FBI very heavily in that regard as well, on training local officers through that.
Just one last question. Chief, you'd mentioned pharmacies, and some of which cooperate, and then there's others that maybe don't as much. And so I'm just wondering what tools are in place. I think it was Banner Elk, North Carolina, that had a pharmacy that was distributing a lot of opioids, and it wasn't necessarily individuals from that town, but it was others coming from, like you said, across state lines. So what is it that jurisdictions can do in situations where pharmacies aren't cooperating? What tools are in the tool set to try and make changes there?
Well, and when I talked about cooperating pharmacies, those were voluntary things as far as public education, community education, working with the pharmacies. We can still investigate. Now, of course, behind that pharmacy is a prescriber. So somebody's got to be prescribing those drugs to that pharmacy to get to distribute out to the public. But by use of the controlled substance reporting system, again, we used to have to go through those diversion agents through the SBI, but now our local agents can actually track that from the very beginning, from the prescriber through the pharmacy to the end user, and make a case that way. Again, when we talked about working with the pharmacies, some would cooperate, some wouldn't. What I meant there was, as far as the community education piece, the mom and pop, the local pharmacies, that, yeah, bring it on in. When you deal with the corporate, they have to get permission from corporate headquarters somewhere out in the middle, somewhere not far away from Waynesville, North Carolina. So I didn't mean to say they weren't cooperating as far as investigations, but if your local agents have access to that controlled substance reporting system, they can make the case involving not only the pharmacy, but obviously the prescriber and the end user as well. So it's important that we get our people trained in the CSRS. It's a great tool.
And just a couple things I wanted to highlight. I know a lot of different topics covered today, but just this idea of partnerships, multidisciplinary partnerships. I think you saw pretty much in every panel today the value of those, and also this idea of developing these systems and these roles and responsibilities, these partnerships early on, and they can be utilized for pretty much every topic we talked about today. I think another interesting thing is these sort of quick and ready assessment tools that law enforcement and other partners can use to assess mental health, substance abuse, lethality risk, and also the value of data. We saw that in this presentation, data intelligence, and not just on the front end, but having data, even from what Tom Scott talked about, to track responses and ultimately maybe even to change behavior. So really appreciate the North Carolina Justice Academy for their involvement, appreciate all the speakers, and also the great staff here at RTI, our team, a couple folks just in particular to highlight, Peyton Attaway really put on a lot of this and was kind of one of our main coordinators. Also Cameron Johnson, Cameron Johnson, who was running the online and taking questions, and Andre Richards, who helped put this together and helped us MC a lot of it. In terms of certificates, we have Peyton's arranged them outside. If you haven't gotten yours yet, for folks that have already left or for folks online, contact the Justice Academy or us, and we'll make sure to get those to you. And like I said, this is something that we want to be an ongoing resource for the community, for the state of North Carolina, and even outside of North Carolina. We've already heard about some good ideas and topics for coming symposiums, but we want this to be an ongoing conversation. So if you got ideas, you want to think other things that we can help you with, questions, we want to be that ongoing partner that you can rely on. So again, appreciate everyone coming out, and have a great weekend.